association of circulating tumor DNA, and this is done before tissue diagnosis, or the tissue diagnosis is still awaited, and the association with time to treatment among patients with suspected advanced NSCLC. And ACCELERATE stands for Accelerating Lung Cancer Diagnosis Through Liquid Biopsy, and this was done at the Princess Margaret Cancer Center led by Dr. Natasha Lell. So the key points or the main hypothesis question was, can we improve time to treatment using ctDNA genotyping before tissue diagnosis among patients with suspected or advanced lung cancer? Also, the optimal way to integrate liquid biopsy, that is the plasma first approach, in the diagnostic algorithm of newly diagnosed NSCLC patients remains unclear. So this is the usual diagnostic algorithm when the patient initially presents to a multidisciplinary tumor board, where they did do a diagnostic biopsy, complete staging, then by week 3 the testing reports are available, by week 4 the further IHC testings and the NGS testing is processed, then by week 5 the NGS results are available and treatment is started by week 6. So the main question is, if we draw a sample for liquid biopsy at the initial visit, that is time point 0, will it make a difference in time to treatment initiation? So the results of two major studies form the backbone of our current study, that is cfDNA is non-inferior to tissue diagnosis for newly diagnosed NSCLC patients, and this was done by Dr. Natasha Lell herself, so where tissue genotyping versus cfDNA. So there was more amount of mutations picked up in the cfDNA as compared to tissue genotyping. They used the Guarded 360. And for FDA approved targets, the concordance was more than 98%, with a 100% positive predictive value for cfDNA as compared to tissue. The same group also did a pilot study, and they found that plasma DNA that is picked up, that is those that are done at the first visit, do pick up mutations, and the time to treatment initiation was statistically significant, that is shorter as compared to those who did after the diagnosis of NSCLC. So this is our study. We started off with 150 patients from 2021 to 2022, and all of these patients were radiologically suspected lung cancer, and the diagnostic biopsy was either planned or performed. Then eventually 139 patients had some form of malignancy. Then from 139 it comes down to 90 patients that had non-squamous NSCLC where a tissue NGS was recommended. And we can see that initially we started off with 150 patients, and only 70% patients were eventually diagnosed with NSCLC. So we need to keep this at the back of the mind that there will be patients for which ctDNA will be processed, but eventually they may either not have malignancy or not have NSCLC at all. So the cost is definitely going to be an issue. The primary endpoint was time to treatment initiation in the ACCELERATE cohort as compared to the reference cohort, and the secondary endpoints were frequency of actionable targets identified using the plasma ctDNA, the time to sample collection, and the turnaround time. So this is the baseline characteristics. I just want to say that the reference cohort was a pre-COVID cohort of 89 patients between 2018 to 2019. And these are the most important results. So when they used tissue alone, 47% of patients had a tier 1 actionable alteration. When they used plasma alone, 51% patients had tier 1 alterations and 22% had non-actionable alterations. It can be an important question that initially they did plasma and later they did tissue. So in the tissue, did they pick up any additional alteration, or these 22% non-actionable alterations in the plasma, did these patients eventually have actionable alterations? So it's very important that amongst these 7 patients who had that is alterations picked up in the tissue, 6 actually did not have mutations picked up in the ctDNA. When they combined plasma and tissue, 59% had actionable alterations. Coming to the most important, that is the primary endpoint, that is time from referral to the clinic to the molecular test results. Using ctDNA, the results were available in 14 days. Using tissue NGS, it was available in 35 days. And time to treatment initiation, using ctDNA, it was 39 days versus 62 days for the tissue NGS. So it was statistically significant. Also, of the patients with driver mutations, 80% could start systemic therapy, And in this subgroup, the time to treatment initiation was even lesser, that is 33 days. It is also important that 23% of patients with advanced NSCLC could start off with the treatment with the ctDNA even before the tissue NGS was available, and the median time to start treatment was 27 days. So to conclude, plasma ctDNA testing before the diagnosis in patients with suspected advanced NSCLC was associated with shorter time to molecular results, that is 7 days versus 35 days, and a shorter time to treatment initiation, that is 39 days versus 62 days. Plasma testing was associated with a greater detection of tier 1 actionable alterations as compared to tissue. Thirdly, nearly one-fourth of patients started treatment based on plasma results after the tissue diagnosis and before the tissue NGS results were available, with a median time of 27 days. But there were certain limitations, that is, it was a single group prospective design. Despite radiological evidence of advanced lung cancer, only 70% of them had biopsy-proven advanced NSCLC. Thus, plasma-first approach does not mean plasma-only approach. Plasma ctDNA-based NGS has lower sensitivity. The reference cohort was from a pre-COVID era, and this could have definitely impacted the results, and the cost implications as what I initially explained. So going back to the algorithm, if we draw a sample for liquid biopsy at the initial visit, will it make a difference in time to treatment initiation? Yes. So this was their proposed algorithm. So if we do a liquid NGS at the start and the liquid NGS is informative, they could start treatment in almost one-fourth of the patients even without waiting for the tissue diagnosis. If the plasma NGS was not informative, then based on what is the ECOG PS and what is the symptoms, they could start treatment on an urgent basis or wait till week 6 till the tissue NGS is available. Thank you.